Hi, and welcome to our Medscape program, Moving the Needle in ER-positive, HER2-negative metastatic breast cancer, exploring SERR strategies to optimize outcome. My name is Nadia Harbeck. I'm the director of the Breast Center at the University Hospital in Munich, Germany, and I like to welcome you. I'm here with a great faculty, Dr. William Gradishar from Northwestern University in Chicago, Dr. Aditya Bardia from UCLA, California, and Dr. Shaheenah Dawood from Dubai Medicine City Hospital. We have half an hour to discuss with you advances in HR-positive, HER2-negative metastatic breast cancer. And before I hand over to my esteemed colleagues, I would just like to review the treatment landscape as we have it today in this setting. We have in the first-line setting, CDK4/6 inhibitors is our standard for the vast majority of our patients. And then in the second-line setting, we don't have an optimal standard so far. We have the option of repeating CDK4/6 inhibitor treatment. We can give everolimus plus exemestane. We have elacestrant in ESR1 mutated tumors, and we have fulvestrant and capivasertib in the AKT pathway altered population. And if patients are doing fine on these endocrine-based agents, we can also repeat one more endocrine-based step. And for those patients where we have exhausted the endocrine-based options, we can move to chemotherapy. And here we have recent data that ADCs are actually better with regard to outcome than standard chemotherapies. And last but not least, for our patients with a BRCA mutation, olaparib or talazoparib, a PARP inhibitor, are superior to standard chemotherapy regarding PFS. And with that overview, I would just like to move to Dr. Bill Gradishar, and he's going to talk about how we can personalize therapy in this setting. Bill, please.
Thank you. And I think Nadia set it up very nicely, because I think the current contemporary treatment of patients with breast cancer is really starting to focus on this tailoring or precision approach by looking at NGS and making decisions based on molecular changes. But there's a broader landscape that we have to take into account. And this slide, although sort of complicated, I think tries to encompass many of those issues. One is, of course, we have to look at the histologic diagnosis. We have to look at the traditional markers of ER/PR/HER2. We have to then subject that material to NGS testing, which may inform our decision-making. But at the same time, and in concert with all of that, we still have to think about the patient. So we have to look at the patient, their comorbidities, what they're willing to receive, what they're willing to undertake, and what side effects they're willing to accept. And all of that is distilled into the treatment options that were nicely laid out by Nadia on the prior slide. So even though it looks like it's a laundry list or a cookbook, there are things that we have to take into account. Next slide. So with NGS testing, which is sort of in a cartoon depicted here, we can either look at tumor tissue or blood, and they each have their potential upsides and downsides. And we try to determine what is identifiable as a targetable mutation. And the key word when we think about that is what is actionable. Because I think when we get reports back from whatever platform we use, we see innumerable things that may be possibly abnormal in the sample, but there are only a handful of them that we actually can act on. And among those, I think, again, we'll be discussing are ESR mutations, PI3 kinase mutations, abnormalities in AKT. If the patient has a germline or somatic mutation, there may be opportunities to use PARP inhibitors. So this becomes a very important tool in contemporary oncology. Next slide. So when we look at the possibility of either utilizing tissue or blood, we have to recognize that there is some limitations. They, in many ways, overlap pretty much very closely, but not entirely. So you can think of circulating tumor DNA in many cases as potentially being more representative of what's going on in the tumor universally across a given patient. if you were to simply biopsy every metastatic site, which no one would recommend, you might find that mutations are present in one metastatic site and not in others, whereas circulating tumor DNA may give a more representative sample. And subclonal alterations are probably more likely to show up in circulating tumor DNA than tissue DNA, which is more likely to identify clonal abnormalities. Next slide. So again, this is perhaps another way of looking at what Nadia presented in her introductory remarks, and that is when we take into account the NGS testing and what it may show us, what we're looking for are specific mutations for which we have therapies. And we'll get into more detail in the subsequent talks, but the things we're most interested in today are whether or not a PI3 kinase mutation is present or other abnormalities in that pathway, including AKT, PTEN inactivation, or whether there are ESR mutations. And this will ultimately inform the treatment options that we have available to a patient. And on the slide, you can see in the second line and third line, many of these options could be utilized in a given patient. And that gets back to my original comments. We have to think about the patient and the side effects and what their comorbidities are, because it may make one choice more attractive for that patient than another. And whether a certain sequence is optimal or not, that is still under investigation. So this will be discussed by our colleagues as we go forward. Next slide. And I'll pass the baton to Dr. Dawood.
Thank you. So I think I have the more complicated task of actually taking you through the journey of patients with hormone receptor positive, HER2-negative metastatic breast cancer. And I think if there's ever been an explosion of data in a subtype of patients with breast cancer, this is probably the one to understand the complexity of it. So I think when I, as a community oncologist, have been learning how to treat my patients, especially with the explosion of data that's come into play in patients with hormone receptor positive, HER2-negative metastatic breast cancer, I think there's several key components that influences the way that I manage these patients, because it influences the journey of these patients through their disease. The first is defining endocrine sensitivity in both stage 4 de novo patients as well as those patients with recurrent breast cancer, because we know that those patients with stage 4 de novo disease have a very endocrine sensitive disease. They're endocrine naive. And in the recurrent setting, it really depends on when they recur. If they recur very early in their adjuvant endocrine therapy, these are the patients that have a more primary endocrine resistance. If they recur a little bit later, but still on adjuvant endocrine therapy, or just a little bit after that, they've got a secondary acquired endocrine resistance. And of course, if they recur much, much later on, they've got a potential endocrine sensitive disease. But it's not only about defining endocrine sensitivity. The second main component when you're thinking about your patient in terms of their treatment is understanding that endocrine sensitivity actually changes over time. Biology changes as you treat your patient along several lines of therapy, as well as understanding that you have these targets that can be acquired over time. The third key component is understanding that you can, in a subgroup of patients, have a change in the hormone receptor status of your patient. About 20 to 30% of patients can actually have their tumors lose expression of hormone receptor, of estrogen receptor expression, and this can be associated with a worse prognostic outcome. The fourth key component is understanding that there are key drivers of endocrine resistance, which can be both ER dependent as well as ER independent. And one of the key drivers of an ER dependent type of endocrine resistance is the development of an ESR1 mutation. And then the most important key component, as has already been discussed, is understanding that there are different biomarkers that can help guide therapy, and actually testing for these biomarkers is important. We know that both at baseline as well as at different time points, because as I've said, biology does change over time and targets can be acquired over time, such as an ESR1 mutation, which is acquired in about 40% of patients who have been pre-exposed to an aromatase inhibitor. Next slide. So a very simplistic view from the clinic is when you have a patient who's got a hormone receptor positive, HER2-negative metastatic breast cancer, standard of care will dictate that you start these patients off on endocrine therapy plus a CDK4/6 inhibitor, assuming that they're not in visceral crisis. Upon progression of disease, you determine if there's a biomarker present or not. If there is a biomarker present and they're not in crisis, you will run through lines of endocrine therapy, usually in combination with targeted therapy, and then go on to systemic chemotherapy. If a biomarker is not present and your patient is not in visceral crisis, again, you run through lines of endocrine therapy, and these data to suggest that you could potentially combine with another CDK4/6 inhibitor where you give it beyond progression, or perhaps even combine it with everolimus. And again, post that, you shift your patient over to systemic chemotherapy. Now, if your patient is perceived to be in crisis, irrespective of the biomarker, it is most likely that you're going to give your patient systemic chemotherapy, following which you will give additional endocrine therapy. Next slide. Now, this year has been the main focus in terms of biomarkers has really been the ESR1 mutation. We've seen several clinical trials that have looked at oral SERRs in the realm of patients who've got ESR1 mutations. We've seen the results of the EMERALD study that took patients who are endocrine resistant, randomized to get either elacestrant, a single agent oral SERD, versus physician choice of endocrine therapy, mainly fulvestrant. And you can see in a non-biomarker selected cohort, patients did benefit from getting endocrine therapy with an oral SERD. But the main benefit, as you can see here on the slide, were amongst those patients who had an ESR1 mutation. And similarly, we saw the SERENA-2 trial, which randomized patients to get either camizestrant, which is an oral SERD, versus fulvestrant. And again, camizestrant was associated with an improvement in progression-free survival in that ESR1 mutant cohort. And then, of course, this year at San Antonio, we did see the results of the AMBER-3 trial that took patients, again, in that ESR1 mutation cohorts, randomizing them to get either physician choice of endocrine therapy, mainly fulvestrant, versus single-agent oral SERD in the form of imlunestrant. And here I'm showing you specifically that ESR1 mutation cohort. We'll be discussing the overall cohort with the next speaker. Again, the progression-free survival was improved in that ESR1 mutation cohort, similar to what we saw in the EMERALD study and the SERENA-2 trial. Next slide. Now, one of the questions that's typically asked is an oral SERD really enough as a single agent in our patients who are endocrine resistant? And here what we see is in patients that were enrolled in the EMERALD study where patients got elacestrant, in those patients with an ESR1 mutation, the prior duration of them having received a CDK4/6 inhibitor could actually influence the progression-free survival of patients. And as these patients had a longer duration on a CDK4/6 inhibitor, you could see that the progression-free survival benefit increased from 2.2 months in those patients with a CDK4/6 inhibitor time duration of more than 6 months to almost 6.5 months the longer they stayed on the prior CDK4/6 inhibitor. Next slide. Now, unfortunately, when you're looking at these Kaplan-Meier curves for patients enrolled in both the EMERALD study and some of the other studies that looked at using oral SERDs as a single agent, you can see a rapid drop in the early portion of the Kaplan-Meier curves, telling us that this identifies a group of patients refractory to single-agent endocrine therapy. You then see the separation in the Kaplan-Meier curves, and this identifies a group of patients who are still retaining endocrine sensitivity where these novel agents do work. So the question that we ask ourselves, can we avoid this drop, this initial rapid drop with combination endocrine therapy? And are there ways that we could potentially identify the more endocrine-resistant patients? Next slide. So what we did see in the AMBER study, there was a third arm to the trial in which they looked at a combination of the oral SERD, imlunestrant, plus a CDK4/6 inhibitor, in this case abemaciclib, and they were compared to the patients who had used single-agent imlunestrant. And what you essentially see is that early drop in the Kaplan-Meier curves is partially reduced. So can we avoid this drop with combination endocrine therapy? My answer to that question is partially. We're not completely avoiding it, but partially we can. And can we potentially identify the more endocrine resistant patients who need combination? Well, we do need to await the translational component of the AMBER-3 trial to see if we could potentially identify those patients who truly do require combination endocrine therapy. Next slide. Now, we have had results from the PADA study that has told us that potentially we could use SERRs much earlier on in the course of patients' treatments when the ESR1 mutations begin to rise without there being radiological progression of disease. And it has been shown to be associated with an improvement in progression-free survival when you switch patients from an AI to a SERD, such as fulvestrant. That's what we saw in the PADA study. We also have the ongoing trial, the SERENA-6, is trying to complement the PADA-1 trial to see if the oral SERD camizestrant can also be used earlier on as ESR1 mutations are detected along the course of treatment prior to radiological progression of disease. Next slide. But it's not only about the presence of an ESR1 mutation, as we've already discussed by the prior speaker, is that we have to look at other biomarkers. And one of the biomarkers that we do tend to test in the clinic is the presence of a PIK3CA mutation for which we do have targeted therapy, such as alpelisib plus fulvestrant, in which we use in combination, or as the Capitello study told us, the combination of a targeted agent for a PIK3CA mutation plus fulvestrant is associated with an improved progression-free survival. Now, what if you had two targets at the same time, a co-mutation, an ESR1 mutation plus a PIK3CA mutation? What would you use first? And again, that's an individualized treatment basis based on an MDT discussion, but you have to recognize that a good proportion of these patients will have a co-mutation. Next slide. But it's not only about a PIK3CA mutation and ESR1 mutation. We have other targets that we need to be thinking about. The presence of a BRCA mutation allows our patients to be treated with a PARP inhibitor. The presence of a pathogenic HER2 mutation, we can use agents such as neratinib, fulvestrant, and trastuzumab in combination as per the results of the SUMMIT study. The presence of an MMR deficiency or a tumor mutational burden that's high can allow our patients to be treated with immunotherapeutic agents such as pembrolizumab or nivolumab. Next slide. So trying to put this all together, let's look at perhaps two algorithms. And I always say we need to split these algorithms apart because we need to look at patients with stage 4 de novo disease versus recurrent disease very separately. Here you see how we treat our patients with stage 4 de novo disease. If they do not have visceral crisis, we give them a CDK4/6 inhibitor as a first-line treatment. Upon progression of disease, you profile these patients' tumors to identify those targets that we could potentially be treating our patients with. If they've got a PIK3CA mutation or an alteration in the PI3 kinase pathway, we can treat them with either capivasertib plus fulvestrant or alpelisib plus fulvestrant. And I've already mentioned the other targeted agents for which we have drugs for it. But where could we potentially add AMBER-3? AMBER-3, which is a combination of imlunestrant plus or minus abemaciclib, could be given to patients with an ESR1 mutation, or perhaps the combination could be used in patients who do not have any biomarkers. Next slide. What about patients who've got recurrent breast cancer? A little bit more complex. These patients, you have to think about whether they've received adjuvant CDK4/6 inhibitors or not. And then appropriately treat these patients. And then, of course, again, where can we add the AMBER-3 trial data? I've tried to present it on the slide over here. We could use the combination of imlunestrant plus abemaciclib very early on in those patients who recur very early, plus post-adjuvant endocrine therapy. But then again, we can use it later on in those patients who do not have biomarkers. So I'll now hand over to Aditya Bardia, who will be taking us a deep dive into the oral SERD realm.
That's perfect. Thanks so much, Dawood. That was a very nice overview, and we'll continue on this theme. Now I'll talk about the SERRs, in particular talk about EMERALD and EMBER-3. So if you look at the clinical trials, EMERALD evaluated elacestrant, EMBER-3 evaluated imlunestrant without abemaciclib, and then SERENA-2 evaluated camizestrant. SERENA-2 was not a registration trial, but both EMERALD and EMBER were registration trials. Two important points in terms of differences between the studies. First is prior use of CDK4/6 inhibitor that was 100% in EMERALD, while it was allowed in EMBER-3 and SERENA-2, and it was not 100% in EMBER-3. And the second difference is the use of chemo, which was allowed in EMERALD but was not allowed in EMBER-3. Next slide. So as was mentioned previously, EMERALD demonstrated improvement with elacestrant versus fulvestrant. The trial was statistically significant both in all patients, so in the ITT population, as well as in patients with ESR1 mutations. The hazard ratios were different. It was 0.68 for all patient population and was 0.50 for patients with ESR1 mutations. And in terms of FDA approval at this time, and EMA approval is for patients with ESR1 mutations based on a hazard ratio of 0.50. Next slide. Now, the question was, can we identify a subgroup of patients who have more endocrine-sensitive disease? So we were seeing this initial drop in curves. Can we identify patients who have more endocrine-resistant versus sensitive disease? And a clinical surrogate marker appears to be prior duration of CDK4/6 inhibitor. So if we look at patients who've had prior duration of CDK4/6 inhibitor for at least 12 months, in that group, the median PFS with elacestrant as a single agent was 8.6 months versus 2 months with standard endocrine therapy. So that was clinically meaningful to see a median PFS of 8.5 months. And that's a surrogate marker that some physicians use in terms of choosing single agent elacestrant. Next slide. And then if we look at ESR1 mutations, we see the same theme, that the prior duration of CDK4/6 inhibitor appears to predict who would derive more benefit with elacestrant, again, median PFS of 8.5 months. Next slide. The second question is double mutants. A subset of patients have both ESR1 and PIK3CA mutation. And the question becomes, should you use elacestrant? Should you use fulvestrant plus capi or fulvestrant alpelisib? So subgroup analyses from the EMERALD study showed that both in patients with PIK3CA mutation as well as wild type, the benefit of elacestrant was maintained. Now note, this is a subgroup of patients. These are patients who have ESR1 mutations and prior duration of CDK4/6 more than 12 months. So it looks like in this setting, the ESR1 mutation is more of a driver of the tumor as compared to a PIK3CA because it's likely an acquired alteration. PIK3CA is more of a truncal alteration, but ESR1 is an acquired alteration. So it's probably that the acquisition of ESR1 mutation resulted in progression of the tumor, and that's why it's more of a driver. And in that setting, single agent elacestrant works. And so that's why you could see median PFS of close to 5.5 months with elacestrant versus standard of care endocrine therapy. And then looking at other alterations, TP53, the type of ESR1 mutations, and HER2 low versus not, the benefit was maintained. Next slide. In terms of toxicity, the number one side effect with elacestrant is nausea. And besides nausea, you see other AEs as well, including arthralgias. So it is something important to remember when using elacestrant. Use of antiemetics could be considered with the use of elacestrant if needed. Now, SERENA-2, this was a phase 2 trial, again, not a registration study, but the bottom line is results were fairly consistent with what was seen with EMERALD. So in the ESR1 mutant setting, you see benefit with camizestrant, and in patients who did not have ESR1 mutations, the hazard ratios were not significant. Next slide. And then in terms of type of ESR1 mutation, that didn't matter with camizestrant either. Next slide. In terms of AEs, that's where camizestrant is different from the other drugs. And as we have multiple SERRs, I think it'll be important to look at the AEs. The side effects that we see with camizestrant include photopsia and sinus bradycardia. Generally does not cause as much diarrhea or nausea as compared to elacestrant or imlunestrant, but it's photopsia and sinus bradycardia with camizestrant. Next slide. And then finally, EMBER-3. This was a trial that looked at imlunestrant versus fulvestrant or exemestane versus combination. It was an interesting design. The study had 3 primary endpoints. The first one was looking at imlunestrant versus fulvestrant exemestane in patients with ESR1 mutations. The second one was looking at this in all patients. And then the third one was looking at imlunestrant versus combination. And this was designed to understand the contribution of components. Well balanced between the 2 arms, about 40% of the patients had ESR1 mutations, and about 40% had PIK3C mutations as well. And 60% had received prior CDK4/6. In terms of outcomes, if we look at patients with ESR1 mutations, very similar to what was seen with Emerald Serena, you could see benefit with imlunestrant with a median PFS of 5.5, a hazard ratio of 0.62. In terms of subgroups, all the subgroups derive benefit, including patients with PIK3C mutations, very similar to what was seen with the subgroup analyses from Emerald as well. Looking at all comers, that's why it's slightly different from Emerald. In all comers, the study did not meet statistical significance. It was a hazard ratio of 0.87. So it appeared that the benefit was largely in the ESR1 mutant group with imlunestrant. And then looking at the combination of imlunestrant abema, it was superior as compared to imlunestrant alone, with a hazard ratio of 0.57, median PFS 9.4 versus 5.5. So it appears that the addition of imlunestrant, the addition of abemaciclib to imlunestrant was superior to imlunestrant as a single agent. Next slide. In terms of subgroups, again, all the subgroups derive benefit, including double mutants. Next slide. This is an important slide. So the question is patients with ESR1 mutations versus without ESR1 mutations. In patients with ESR1 mutations, imlunestrant was superior to fulvestrant, and the addition of abemaciclib to imlunestrant was superior with a hazard ratio of 0.53. So abemaciclib does appear to add to imlunestrant in this setting. In patients without ESR1 mutations, it's difficult to make that call because imlunestrant was not superior to fulvestrant in the patients who did not have ESR1 mutations. And while imlunestrant plus abema was superior to imlunestrant, we cannot say that this is something that's driven by imlunestrant. This could be an abema effect because there's no fulvestrant abema control. This effect could be an abemaciclib effect, which also has single agent activity. And given that imlunestrant was not superior to fulvestrant in the ESR1 wild type setting, it's tough to know that this effect is not driven by abemaciclib based on the study design. In terms of response rate, it was higher in patients with ESR1 mutations, 35% with the combo versus 23% with patients who received imlunestrant single agent. And then it was higher in ESR1 mutant versus wild type setting. Next slide. And then overall survival, immature at this time. Next slide. Safety tolerability, well tolerated. The main side effect with imlunestrant was diarrhea, and the combination diarrhea was the main side effect as well. So we'll bring it back to Dr. Harbeck.
Thank you so much, Aditya, for summarizing the data. We have a few minutes left, maybe for a few questions, just quick answers, please. Maybe I start with you. So do you see the future of these novel SERDs more as a monotherapy or actually as a combination therapy?
I think both. In the right setting, monotherapy does still have value because from a patient quality of life perspective, it has less side effect as compared to combination. But in settings where monotherapy is not sufficient, or does not have activity, then doublets would have a role. They have more efficacy, but then you also add toxicity.
Yeah. So, Bill, you've seen the EMBER-3 data now in the talk. So, how do they change the treatment paradigm for you? I mean, provided that there will be approval. Can you turn on your microphone, please?
I think the good thing for all of us is this represents more options for patients. At a granular level, I think we'll have to look at the individual patient, how they responded to their prior therapy. And most of the people in EMBER-3 got palbociclib. They weren't getting some of the other CDK4/6 inhibitors that are now being introduced in the adjuvant setting. So all of these sort of little nuances are going to play into how we think about what therapy is best for the patient sitting in front of us.
Yeah, right. I completely agree. I'm looking forward to having those additional options. Shaheenah, what do you do with patients with both mutations, ESR1 as well as PIK3CA? Do you have a preferred treatment paradigm there?
I think I think it's an individual decision-making process depending on what you're seeing, whether your patients have a high tumor has a high tumor burden or not, and what their prior endocrine sensitivity was to a CDK4/6 inhibitor. I think all these factors will factor in. We certainly don't have AMBER right now in the clinic. We have oral SERD with elacestrant. So I'm more hesitant to use elacestrant if someone's got a huge tumor burden and a short CDK4/6 prior sensitivity. I'd be more inclined to use a combination endocrine therapy targeting the PIK3CA. But I think that will change as we get the combination into the clinic.
Yeah, definitely. So we're looking forward to that. So with that, thank you very much for those wonderful talks and overviews of the new data. And to our audience, thank you all for participating. And please don't forget to claim your CMA credit by the website or the QR code. And with that, I wish you all happy holidays and all the best for the new year. Thank you.
Thank you.
Bye.